It's my honor and privilege to invite our next speaker, the very distinguished and esteemed personality, Dr. R.G. Patel, sir. He's going to talk on how to deal with the poor responders. He's actually achieved his achievement is very much, but I have to describe. Everyone here know him very well. He is a director of Sunflowers Women Hospital, Ahmedabad, and having a 20-year of experience in IVF. He selected as one of the member of expert committee at the Central Board of ART and Surrogacy Regulation Act 2021 in Central Ministry of Health and Family Welfare, New Delhi. He awarded for Best IVF Center in India 2012 Independent Survey by India Today Group. He was awarded Bharat Ke Ratna Gujarat Se Award on 2023 by Smriti Irani. He was awarded he was president for Gujarat chapter ISA 2024 to 2026. And he is a member of ASHRAE, ISAR, IFS, FOXY, SOGOG, and AOGS. He delivered many lectures at national and international forum on IVF and infertility. He is a pioneer in male infertility, including TESA, micro-TESA, with special interest in repeated IVF failures. He published various clinical research papers, oral and poster presentation at international and national conferences. He delivered more than 20,000 IVF babies successfully. So big round of applause for R.G. Patel, sir. Actually, sir, we are very lucky to have you here.
Thank
and
you.
so now the stage is yours, sir.
Thank you, Chairperson. Thank you, seniors and all the delegate. Without your presence, this conference cannot be successful. I'm very happy to see you all in hall, full presence, to learn so many things in IVF. We know IVF cycle is increasing, acceptance is increasing, result is also increase, complication decrease, and that all because of technology, timing, good gonadotropin, good monitoring, good laboratory work, antagonist cycle, GnRH analog to prevent the OHSS free clinic, maximum blastocyst production in the IVF lab, and transfer in a frozen cycle, increase the success of IVF, decrease the abortion rate, decrease the ectopic rate also. That leads to flourishing of all the IVF center, and demand from the society is also too much. Acceptance is good. So we have need result of IVF, good success rate. For the good success of IVF, we need good egg, good sperm, patent and potent fallopian tube, good receptive endometrium. But challenge remain challenge. Repeated IVF fail, decreased ovarian reserve, egg problem, genetic problem. Already Dr. Bhavish here told about the thin endometrium, and our young andrologist talk about the azoospermia, micro-TSA. So some challenging is remain challenging. Education is increasing. People need their own egg, own sperm, and in own uterus pregnancy. So we need good egg. If egg is less, ovarian reserve is less, the number of egg may be less. Number of embryo formation may be less. Pregnancy rate will be less. IVF attempt will be more. And abortion rate will be high, and anomaly is also high. To avoid this, we have to understand how to tackle the poor ovarian reserve. And now, because of ART law, there is a scarcity of the donor. So always try with the own eggs. We know risk factor, age, low MH, AFC, obesity, infection, previous poor response, previous surgery on ovary like endometrioma, PCOD drilling, genetic factors like Turner syndrome. We have seen Robertson's translocation. How many have faced Robertson's translocation in IVF? We have many cases. And the chances of good blastocyst formation is only 16%. We have stimulated 5 times. And 2 blastocysts were formed. And patient become pregnant. So genetic is also one of the reason. Same single ovary or chemotherapy or radiotherapy, they are likely have just poor responder. We know Bologna criteria, by definition, age more than 40. If previous stimulation having less than 3 egg, AMH less than 1.1, or AFC less than 5, that all together we can suspect this is a poor responder. And to define and to good guideline how to tackle each and every poor responder, there is a Prosodian criteria. All renowned scientists of the world, Carlo Evigi, Sandro, and Peter Humedian led Prosodian criteria. So 1, 2, 3, 4. Young having normal reserve, that is Prosodian 1. Older but having normal ovarian reserve, that is 2. Young but poor ovarian reserve, that is Prosodian criteria 3. And 4 is poor with old age. So each has we have to tackle individually. Now we have to see the AFC. Out of all AFC, how many follicle is developed? That is follicular outcome rate. So how many AFC there and how many egg you retrieve? That is follicle to oocyte index, and it should be around more than 50%. If it less than 50%, that is your poor out index. We know each and every egg is very important. If you have 1 to 3 egg, the chances of pregnancy is 21%. But if it more than 9, around 40% chances there. More than 15, around 50% will conceive. If it is more than 15, then 60%, 70% will conceive. So each and every egg is very important. Higher the number, higher the chances of pregnancy, cumulative pregnancy rate is there. For the management of the patient, your thorough investigation of the patient is important, and your counseling is very important. Because here you need counsel the result will be less. You need good gonadotropin, high dose maybe, good quality of gonadotropin, sometimes one stimulation, sometimes second stimulation. Many patients are coming by religious or by because of education, they not believe in egg donation, not at anyhow they want egg donation. And we have done double stimulation, triple stimulation, 4 times stimulation, even 5 times stimulation. Because of some genetic problem, obesity, diabetic, BP in patient, they need multiple time of stimulation. So we have to understand that patient about their cost, each and every cycle may cost. Chances of embryo formation may be less. Try to produce maximum blastocyst, then we will transfer. But because of less egg, the chances of embryo blastocyst, good quality, euploid embryo chances will be less. So how will you deal it? That pre-treatment, then protocol, maybe antagonist, maybe short, long protocol, gonadotropin, what is the role of high dose, what is the role of LH, what is the role of growth hormone, and triggering. So what will do pre-treatment in those who are not patient young, having less ovarian reserve, and having 1 or 2 year active married life, we not go for the IVF directly. We can give some medicine, counsel the patient, give some medicine, and sometime it work. Folic acid, B12, D3, lifestyle modification, give some coenzyme, antioxidant. So coenzyme Q will energize the mitochondria, and the chances of good ovarian reserve will be then. Spontaneous pregnancy we have seen many with the coenzyme Q10, and with we have to give for 3 months. Dose may be 300 to 600. Again L-arginine, again omega-3 fatty acids, all are increasing the ovarian reserve. What about the resveratrol? This is a costly molecule, but it will improve the egg quality and increase the pregnancy rate. So what about DHES and what about the testosterone? This testosterone you have to give for at least for 1 to 2 months. That will synchronize the follicle, that will increase the FSH receptor, increase the egg quality. But don't give more than 3 months, don't give high dose. If you give DHES, the dose is 75 milligram, maybe 25 milligram 3 times a day for 3 months. and that will improve the FSH receptor and increase the egg quality. Now you need synchronization. You have to give some medicine before starting stimulation. Three way you can do that: estradiol valrate, 2 milligram twice a day from the 18th day of the cycle, or you can give 10 days of OCP. Don't give full dose of OCP. You can add antagonist 5 days, 7 days before 5 days. So that is the way you can do synchronization. Estradiol valrate, low dose of OCP or antagonist. So now what about stimulation? There are lots of protocol. Higher doses of gonadotropin, use of LH, stop GnRH analog protocol, androgen pretreatment, uh, recombinant or urinary, growth hormone, antagonist program, use of letrozole or clomiphene citrate, luteal start of the FHS, luteal beginning of the GnRH analog, or lower HCG dose, low dose of HCG during stimulation. So we don't go in detail: long protocol, short protocol, ultra short protocol, microflat protocol, antagonist protocol, and stop protocol. The dose you have to calculate depend on the AFC, AMH, age, and weight of the patient, previous history. You can start normally 225 or 300 will be suffice. But here you may need little high, maybe 300, maybe 350 dose of FHH. If you give more than 400 or 500 or 600, previously we have seen 600, even 900 in a poor responder, but study showing if you give more than 350 of FHS, there is no role. Your result will be decreased and cost will increase. So no role of more than 350 FHH. Growth hormone is very debatable, vital costly. You have to give 4 units from the day one of the stimulation. Last X-ray and SRM have showing study by showing that will improve the result. So it is a debatable because of cost and multiple injection. But in few selected cases, you can give growth hormone 4 units from day one of the, or even 8 units you can give from 21st day of the previous cycle. So what about LH? LH is needed for the poor responder. LH level between 1 to 5 is needed for the normal folliculogenesis. If it is less LH, less estrogen will form, less number of follicle will respond. If LH is high like PCOD, then atresia or premature LH surge will be there. So LH during the stimulation should be normal. Then you can expect good outcome. So what dose you will give? So if you are already poor responder, you can start FSH 350 or 300 with 150 LH, recombinant LH, already known poor responder. Normal responder, you have started normal dose of FHS. On the day 6, you find there is a hypo responder, less number of follicle. With the FHS, you can add 150 LH during on day 6, after day 6. That is hypo responder or slow responder. What about more age, more than 35? Then you can add LH 75 from day 1 of the stimulation. So different protocol, different patient in different situation, but LH will help. Whether you will use recombinant or urinary or HCG driven LH. In menopause, it is HCG driven, and many few company having. It's a long acting, but low dose HCG, long acting, and a cheaper one also. So recombinant LH, precise dose you can give, but this I prefer recombinant, but you can give HCG driven or even urinary LH you can give. So what are the main indication? Old age, hyporesponder, poor responder, or in a down regulation long protocol, if you see the LH is less than 0.5, you need LH to add in a long protocol, or less oocyte in a previous cycle. So again, recombinant or urinary, same. Why in young PCOD, good ovarian reserve, you not get the good response after starting FHS because of FHS polymorphism. That FHS polymorphism, you need to start more high dose of FHS. Same way LH polymorphism, you need high LH for the LH polymorphism. Then you can treat the patient. So FHH and LH polymorphism is very important. Those who are unexpected response. So again, you have to do for the blood test FHH and LH polymorphism and do accordingly. What about oral medicine? Cheaper one. Clomiphene cited in a poor responder, X-ray guideline, yes. You can give 100 milligram clomiphene cited with HMG is a time-tested medicine. Letrozole, because of monofollicular, normally we can avoid in a poor responder. X-ray, we not suggest to give letrozole in a poor responder. IVF, again, we have seen, again, long protocol or antagonist protocol, more prefer to antagonist protocol because of less number of injection. What about progesterone prime estrogen in a poor responder? Okay, to avoid the LH surge, we can give progesterone to avoid the antagonist injection during the stimulation. But my experience is not so good in a poor responder. In PCOD, it's good to give progesterone to avoid the LH surge. Again, natural cycle, modified cycle, mild stimulation, conventional stimulation, CC, gonad HMG 150, HCG, and you can start. That is keto protocol. Previously, we know only one, we can start in a follicular phase. But now, random you can start. Even in luteal phase, you can start. Because of, there is a 3 follicular wave theory during one cycle. So, in the same cycle, you can give in a luteal phase also, in a follicular phase also. In the same cycle, the dual stimulation you can do it. So, that way you can do dual stim. That is our preferable method to give start recombinant FHH 300 unit and 150 recombinant LH for 9 days and start gonadotropin on day 6 and give analog triggering, not HCG triggering. Give MPA to avoid the LH surge, do ovum pickup. After 5 days, again you can start the same regime, same antagonist, and you can trigger with analog and do second pickup. So in the same cycle you can do. This is a dual stim. This is Shanghai protocol, very cheap, very easy to do. Clomiphene citrate, letrose, and 3 doses of HMG. Give Maprate or indomethacin to prevent the LH surge, to prevent the rupture. You can give analog, do pickup. After 5 days, again start the stimulation with the letrozole, with HMG. Give MPA to avoid the LH surge. Do second pickup with analog. So this is a Shanghai protocol, same cycle. Those who have less time, you can do embryo pooling in a same cycle. So double stimulation is also important, analog with HCG and triggering. So embryo pooling is one of the best method as per poor responder is concerned, but patient counseling is very important. Double triggering, sometimes you not get enough egg after triggering. So give analog with 40 hours and HCG 34 hours. That is known as double triggering, but timing will be differ. Normally we suggest analog with HCG is the double triggering, but here also timing is differ. In those who have unexpected less number, less mature egg, then you can do this type of triggering. Again, each and every egg is important, so go for double lumen needle, flushing of the egg to maximize the number of egg. And freeze-all, absolutely fine. Nowadays, almost 90% we are doing freeze-all cycle, produce maximum blastocyst, transfer in a FET cycle, natural cycle, or estrogen prime cycle. The result will increase. Again, ovarian rejuvenation by PRP, by stem cell, already discussed. So we not go in detail. But PRP we have to inject in a ovary. 1 month you have to wait. Second, again you can do it. Again, so twice or thrice you can do PRP. But very difficult. Experience is required because ovary is small. Whether you do transvaginal or whether you do by laparoscopy is debatable. But I used to do by transvaginal. Transvaginal by with the PRP with the augmentation with the calcium sulfate. So PRP we are doing and good result. Again, autologous stem cell from the iliac crest, find it out and you can inject in the ovary also. Same way autologous, you can augment in vitro follicular activation. but not much popular. So at present, it's a autologous mitochondria, because you cannot transfer mitochondria from the donor. This is ban. But autologous, you have to find out the primordial follicle and take out the mitochondria, inject own egg to augment the, to energize the own egg. That is known as autologous germline mitochondrial transfer. So this is all in a research purpose. What you will do best care in the laboratory, because this is the less number of egg. You need experienced embryologist to carefully handle, maximize the, mostly we are doing ICSI. So here no role of IVF, careful handling also important. What day we will transfer, day 2 or day 3, because no less number is there. You can freeze day 2 or day 3 one if you are doing for the freeze-wall cycle. If you are going long protocol, ovary is okay, endometrium is okay, number of follicle and transfer fresh, even you can do day 2 or day 3 transfer. So again, tailor made depending on the situation, day 2, day 3, but result always better with the day 5 blastocyst. So what about PGTA? Because this egg is already pathological, but number is less. How will you produce maximum blastocyst? You want to do PGTA, but blastocyst तो बनना चाहिए ना. તમારે PGTA કરવું છે, result 2 fail, 3 fail, 5 fail, even genetic reason છે, and you are planning for the PGTA in a poor responder. But scarcity of egg, sometime blastocyst will not form. So double stimulation, triple stimulation, embryo pooling, then you can do PGTA in a few suggested cases. Otherwise, routinely in a poor responder, PGTA will not help. Again, you can do site rectification, those who are not planning for the pregnancy, not planning for the marriage. If you have a poor ovarian reserve, you can do egg cryopreservation. We have done many cases. Mostly medical student, abroad study, and they have done egg freezing during their visit in India. So this is one of the option, oocyte vitrification. Again, we know egg donation, whenever the tried and genetically not good, egg not good, not producing embryo, all PGTA abnormal embryo, then last resort is egg donation. So management of poor responder is tailor-made, individualize the patient, individualize the stimulation, based of the best IVF care, and transfer should be very consistently to result oriented. And thank you very much for the patient's hearing. Thank you very much.
Hello. Thank you, sir. I must say it was truly enriching. Thank you for expanding our knowledge. Any questions to sir from the audience?
Whenever you do ovarian PRP, are you stimulating ovary with a
No,
follicle?
no. No, because immediately you have not to stimulate. You have to wait.
Okay. No, only tablets, clomiphene citrate or letrose. So can we do easily PRP? Intrauterine PRP,
No.
intra-ovarian, no need.
No. Ovarian PRP, you have to wait for 2 to 3 months for the to effect the platelet. This is a growth factor, and growth factor will have a time to regenerate the follicle and growth.
I am asking, whenever you are planning to do the intra-ovarian PRP, at that time you are giving clomiphene citrate for 5 days for making
No.
a big ovary?
No.
Oh.
But you can give it, because small, very small ovary, even are sometimes difficult to find, because you have to press, give the best anesthesia, you need experience, then you can precisely inject in the ovary. But if you stimulate, then you follicle will you can see, and it's sometimes it easy. Yes, you can do with CC 1 or 2 follicle, then do PRP, and then you can stimulate.
Sir, what is your specific treatment for poor responder patient? Before you start the stimulation, are you going some medicines that
Yeah. Always counseling, lifestyle modification, even few medicine also. Because many, like in Saurashtra masala, low hemoglobin, some platelet problem, thyroid problem, and after 35, so many have frank diabetic. First time we are diagnosing. Thyroid even. So many medical problem in male also, female also, that we have to correct. During that time, we can give whatever the problem they have, we can give some supplement. Routine antioxidant plus omega, coenzyme Q, resveratrol, and if needed, we do PRP, then we start the stimulation. If patient not no time, then we can start. If ovary synchronized, we can see 3-4 AFC and based ovary synchronized, then without wasting time, we can start the stimulation. Because if we give some medicine, there is a desynchronization of the follicle. If you give 1 month DHAS or coenzyme Q or some medicine, then on day 3, next month, the discordant of the follicle, then it will be in trouble. Again, you have to give progesterone or like this to do synchronization. So if follicle is based, AFC is based, 3-4 AFC, you can start.
And one more. In transvaginal intraovarian PRP injection, what type of needle should be used? Is it normal OM pickup needle or with a lesser number of?
Because if you thin out the needle, the piercing force will be high. Then your ovary will move.
Yeah,
So
otherwise also unstimulated, smaller, poor responder ovaries are very small, and it's very difficult to puncture by transvaginal route, and you are more likely, much liable to puncture the major vessels also. So is it recommended better route is laparoscopy or transvaginal?
yeah, it is a very small and previous history of operative adhesion or endometriosis. Better to do with the laparoscopy. But with the we are used to do it because of experience. But because laparoscopy again invasive. We are planning for the laparoscopy. I think nobody doing laparoscopically. By theory, they have done take the lecture everything, but theory by theory because it's a limited role. After even PRP, we don't know. Same in endometrium, same in ovary also. So invasive, better to avoid. Practically, we are not doing laparoscopy. By transvaginal, if feasible, ovary is seen, we can do PRP, and you can repeat after 1 month.
But sir, so many things we can find out by doing laparoscopy, adhesion, endometriosis, and so many things. Suppose just we do ovarian PRP, it is very little bit blindly. If you do with laparoscopy,
Yeah,
it will
yeah.
be only 5 mm.
During
you will get more information regarding the pelvis. So
if you are doing laparoscopy and patient is for IVF and poor responder, at that time you can do PRP with the laparoscopy. Same time, same setting.
Sir, one theory, scientific. Last yesterday in Amsterdam, I heard, listened this lecture, in where many patients with poor ovarian reserve, we do medicinal therapy, DHA, coenzyme Q10, testosterone, everything. And after doing all these therapies, and many patients will improve, AFC count will improve, and some patients will not improve. And if we leave the patient for some period of time, then automatically the ovarian reserve will improve, AMH will improve, and what they explain, like there are somatic cells, they convert into the progenitor cells. So is this theory
Yes. That is, we have seen many cases spontaneous conception. Even after 2 IVF fail, if you give some medicine, and sometimes they conceive naturally. We have seen many cases. But this is more possible in young age. Young, poor responder, and then if we give this medicine, that will sometime miracle result. Spontaneous pregnancy also we have seen, but in the same poor responder, young age will respond well.
I think we are running short of time, so maybe we can keep question answer session during lunch hour. So to keep up the time. Thank you so much, sir.